Hello, everyone, and welcome to this Global Health Conversation series. I am Dr. Gillian Stressen, and I will be with you today with Professor Mbacham and Professor Nji. Just quickly to mention that this session is being recorded and will be available for viewing after this presentation is completed. So briefly, we have two presenters today. So one is Professor Mbacham. Professor Mbacham earned his PhD from Harvard and has had a very distinguished career since. He is a professor of the Faculty of Medicine and Biomedical Sciences at the University of Yaoundé I, where he's also the chair of the Unit for Research and Graduate Training. He has supervised more than 60 master's and medical students, 20 PhD students, and has over 100 publications in a range of topics, focusing on molecular surveillance, drug resistance, co-infection, all the way ranging to economic and cost-effectiveness work. He's also the president and founder of the Fobang Institute for Innovations in Science and Technology, or PA.S.T.E.U.R. This institute provides educational programs ranging from vocational courses, as well as receives internationally competitive research funding, including a current project on evaluating a malaria chemo prevention program targeting young children. In addition to training some of the most influential malaria academics in Cameroon and internationally, other accolades include being the executive director of the Multilateral Initiative on Malaria, serving as the coordinator of the Anti-Malarial Drug Resistance Network at the World Health Organization. He's also the vice chair for research for malaria and capacity development for West and Central Africa, and has recently been sworn in as the new chairperson of the Board of Trustees of the Malaria Consortium, an international nonprofit organization specialized in the comprehensive control of malaria and other communicable diseases. With us today, we also have Dr. Nji. Dr. Nji holds an MSc in Applied Statistics from University in Belgium, as well as a PhD in International Health Medical Research from Ludwig University in Germany. He's a senior lecturer and professor of biostatistics at the University of Yaoundé I, and is the head of the Clinical and Laboratory Data Management Unit of P.A.S.T.E.U.R. He's also played a major role in the design and running of multiple clinical trials and research projects on anti-malarial drug effectiveness and efficacy. He's supervised dozens of MSc and PhD students and has contributed to multiple scientific publications. He's also the consultant clinical data monitor for the WHO trial on tuberculosis drugs, is a member of the Society of Epidemiology in Cameroon, and is part of the network of modelers in tropical diseases, the recipient of Marcad Fellowship, and is a member of the Modeling and Simulation Hub in Africa based out of the University of Cape Town. Both have a wealth of experience in global health, and although I've only shared the tip of the iceberg when it comes to their interests and accomplishments, their work is generating a substantial and lasting impact in the field. And I do consider myself fortunate to have them as collaborators and friends. Today, we will speak about important emerging issues facing Cameroon and other countries around the globe and in Africa, the dual burden of disease. So we will start with a presentation and then have some time for questions and discussion. So please put any questions you may have in the Q&A and we will go through them after the presentation. So with that, I would like to hand it over to Prof. Mbacham.
Well, thank you very much, Gillian, and it's a pleasure actually having to share the stage with you. I'll be presenting on behalf of both of us, therefore, Akindenji and myself. And I christened this talk, the convergence of the twain, just to show you that there's a dual burden of infectious and chronic diseases, and these are becoming present in a single individual. In the next slide, it shows us just the plan. I'll be talking about health research and development inadequacies in low and medium income countries. I'd also take on the rise of chronic diseases, which are also considered non-communicable. And I'll talk about inflammation, which is central in the etiology of these diseases. And finally, I'll make a pledge or a plea or an advocate that Africa should launch its health research agenda in P.A.S.T.E.U.R's quadrant. So if we can start in the next slide with the health and research development inadequacies. It just shows us basically that most of the African nations are poor. There's limited resources and which are directed more or less towards emotional needs And the limited resources are also misguided by political strategies. There's limited resources that do not favor proper budgeting, and the rational thinking is so weak, and we cannot look for alternatives. And the health gains are not directly palpable, and this makes it very, very cumbersome. The world's poorest nations have the highest burden of disease. In the first map, you find the gross national product, and the darker the red, the more rich that nation is. And when it comes to the malaria index, a click. Could you click on? You also find that the darker the nations in red, the more rich they are, but this time it's not in wealth, it's more for malaria. In the next slide, I demonstrate that the health of low and medium income countries is in peril. It is disenfranchised by and dictated more or less by war, by famine, and by natural disasters. When we have to mobilize funds for research and for health, it's sometimes too slow, too late, and very little of it comes in. And improvements are therefore needed on some of our imperfect tools, and to also boost up some of the insufficient knowledge that we have. And there's still so many gaps that we need to clear, we need to fill up. When it comes to the health needs, there is need for a stronger health system and infrastructure. We need to change habits amid competing health and social priorities. And we need to focus more on a more biological-based perception of what disease and health is. Otherwise, we subscribe it more or less to witchcraft. In the next slide. I therefore bring to you the fact that we're facing a twin trouble, and this twin trouble is one of comorbidity, respiratory tract infections, bacterial infections, congenital diseases. With a gradual drop in infectious diseases and longer life and better wealth, there's a rise in chronic diseases, but the habits could resolve this. Diabetes, we know, is emerging very strongly. Cancers, cardiovascular disease, obesity are beginning to confound the picture. So this rise in chronic diseases or non-communicable diseases is what I want to bring to you. We've just recently seen in the literature, and it's been demonstrated that annually 77% of all non-communicable deaths are in low and medium income countries. These are ascribed to cardiovascular, to cancer, to respiratory diseases, to diabetes. And these four groups account for more than 80% of all premature NCD deaths. Now, if we could detect and screen and treat the NCDs as well as provide enough palliative care, this would be a key component of the response to these non-communicable diseases. The non-communicable diseases kill about 41 million people each year, equivalent to 71% of all the deaths globally. Each year, more than 15 million people would die from NCDs between the ages of 30 and 69. And this is something we cannot tolerate because it's taking away the workforce. Tobacco, physical inactivity, are harmful use of alcohol and unhealthy diets are all increasing the risk and the numbers that are dying from NCDs. In the next slide. I show you this picture to demonstrate the dailies that result from non-communicable diseases, but are attributable to infectious diseases. You will notice that Central Africa, Eastern Africa, Western Africa, and Southern Africa, besides Oceania, are actually topping the rank. And again, this is something which could be avoided if only we could change habits. In the next graph, I show you that in the 90s, what we had as communicable disease was just about 21.4%, and communicable disease was about 73. But in the next slide, you notice that in 2017, the communicable disease has dropped to 61, has dropped to 61, but the non-communicable disease has risen to 32. And this is beginning to be worrisome because the physicians have not been trained to look at these comorbidities together. And so rather than treat an individual for what he is presenting at the hospital, they need to focus on the presence of more than one disease outcomes, polyparasitisms, but also these non-communicable diseases. In the next slide, in Cameroon, I demonstrate exactly how the numbers have been playing from between 1990 and 2017. And you notice that malaria and neglected tropical diseases rose in the mid-2000, 2005, but up to 2017, there has been a gradual drop. Meanwhile, if you look at the cardiovascular cancers and digestive diseases, you notice that they're slowly rising. So there's a point at which these two would come together, and we do not know exactly how to handle both situations. In the next slide. Well, I demonstrate that there's going to be this convergence of non-communicable diseases and infectious diseases. And when we look closely at them, they share very common features, such as long-term care that is needed and an overlapping of the high-risk populations. Now, we notice also that effectively, if we look at people who have some of the non-communicable diseases, then there's a tendency that they are even more susceptible to the infectious diseases. And this is exactly some of the things that bothers physicians when they're trying to provide care. In the next slide, I show you that besides malaria and the NCDs, the addition of HIV in sub-Saharan Africa has made it a triple jeopardy. And effectively, physicians who are now trained to handle all three are beginning to have an insight, a little bit of an insight on exactly what it is that could be happening. And in the next slide, I introduce, therefore, the topic of inflammation that is central in the etiology of diseases. Now, what is inflammation? In the next slide, inflammation is a condition which is just a coordinated immune response to harmful stimuli. This can be infectious agents. It could also be tissue damage, or it could be cellular irritants like toxins. And the cardinal signs of inflammation are those of heat, redness, swelling, pain, or loss of function. Now, in chronic inflammation, in the etiology of disease, as you'd see in the next slide, is one in which the immune system and the inflammatory responses are involved in a number of disorders, but a wide variety of mental and physical health problems are also beginning to take the center stage. Evidence is emerging that the risk of developing chronic inflammation may be traced back to early development, and its effects are now known to persist throughout lifespan to affect adult health and the risk of mortality. The subject of epigenetics is one that we are familiar with, and these intermittent increases in inflammation are critical in survival during physical injury and during infection. But recently, a condition called the systemic chronic inflammation has been described. Now, systemic chronic inflammation can lead to several diseases that collectively represent the leading causes of disability and mortality worldwide. In Africa in particular, and the understanding of this is such that the multi-level mechanisms underlying SCI and several risk factors includes infections, but also physical inactivity, poor diet, environmental and industrial toxicants, and psychological stress. In the next slide, it shows you that the triggers of systemic chronic inflammation are things like chronic infections, physical inactivity, obesity, dysbiosis, dieting, isolation and chronic stress, disturbed sleep, and xenobiotics. Meanwhile, the consequences of systemic chronic infection triggered by those on the left are things like the metabolic syndrome and type 2 diabetes, cardiovascular disease, cancer, depression, autoimmune diseases, neurodegenerative diseases, sarcopenia, and osteoporosis, as well as immunosenescence. In the next slide. Meta-inflammation is a low-grade inflammation, which is a common feature of chronic metabolic disorders and is believed to promote disease progression. And if we could modulate inflammation, then we could explore ways in which these comorbidities could be properly handled. Innate immune memory could underline the meta-inflammation in the context of the metabolic syndrome. In the next slide, I show you that innate and adaptive immunity are just ways in which the body would respond rapidly in the case of immune innate immunity, or would be slow, in which case it uses its response and memory to provide adaptive immunity. And in that case, many cells are involved. But what we take home with this is that the innate immunity's role has been understood better since the start of this century. And in the next slide, we show you that this innate immunity's role traditionally was seen as the first line of defense, which is still true, but now the innate immunity has emerged as a sophisticated system of sensing signals of danger. We saw this in the case of COVID, and much more was understood. It's activated by the engagement of the germ cell line encoding the pattern recognition receptors, which pattern recognition receptors recognize the presence of microbial pathogen-associated molecular patterns or the danger-associated molecular patterns. In the next slide. In all of these inflammatory responses, you have a multi-protein oligomer consisting of peptides, caspase-1, sometimes caspase-5, but there are a plethora of other proteins and peptides that are involved, which are expressed in the myeloid cells as a component of the innate immune system, and the exact composition of inflammasome depends on the activator which initiates this inflammasome assembly. The inflammasome promotes the maturation of the inflammatory cytokine, such as the interleukin-1 and interleukin-18, and there are many other cytokines, pro-inflammatory cytokines, that have been involved. In this picture, I just show you the complex of the cascade of reactions that results in the assembly of the nut-like receptor P3 inflammasome, which you would find effectively on the right side of the screen. And just to show you that even our diet can induce trained immunity. In the next slide. In this other slide, just before we go to the next slide on diet-induced trained immunity. No, stay on this one with malaria. Okay, just to show you that effectively when malaria induces the assembly of its inflammasome, and it could actually lead to a superinfection with bacteria. So basically, it is one condition is exacerbating and promoting the others. Just in the interest of time, I could not show you all the different mechanisms by which malaria would cause or would be exacerbated because there's cancer or diabetes present and vice versa. So basically, the comorbidities and these infections is something that is very worrisome. And the more we start to focus on things which could be the commonality in these infections, maybe we'll be able to provide some infections. But that's still a long shot away. However, inflammation in itself can be caused by things that we eat. And in the next slide, you would notice that, in the next slide, that inflammatory conditions such as infections or obesity can lead to systemic inflammation. Now, dieting is something that we need to think about because it causes one of those inflammatory conditions known as obesity. Consequently, interleukin-1b can mount and can evoke immunological reprogramming of the myeloid precursors in the bone marrow. And these changes will promote increased proliferation of the hematopoietic myeloid precursors. In the next slide. I just demonstrate exactly that inflammation can result from anything from cytomegalovirus excess pathogens to HIV-associated fat metabolic syndrome, to HIV production and replication, to the loss of regulatory cells, or to microbial translocation. And this inflammation can cause the comorbidities and result in our aging process. In the next slide. I think we dealt already with this. I'd like to go. So I conclude by saying, nope, one slide back. I conclude on the issue of inflammation to say that inflammation with diseases severity In diabetes, there's inflammation with disease severity in diabetes, obesity, Alzheimer's, malaria, HIV, bacterial superinfection, and atherosclerosis. The node-like receptor P3 is a major player in inflammations and is central in a range of disease states. Understanding these conundrums may point to new forms of therapy. In the next slide, I argue that Africa should lodge its health research agenda in Pasteur's quadrant. Now, what do I mean by this? In the next slide. So Africa's health research, by having to lodge in Pasteur's quadrant, simply means that when we look at research and have it as consideration for you, sometimes the answer is a yes, or it can be a no. But when we have the quest for the fundamental understanding, the answers can also be a yes or a no. When we create a contingency 2x2 table, it results in 4 quadrants. Now, in the quadrant in which Louis Pasteur is found, we need to look at the fundamentals, but also look for how this can be applied in the resolution of our issues. And that is where Africa needs to lodge, in Louis Pasteur's quadrant, which is the top right quadrant of this 4x4 table. By us lodging in Pasteur's quadrant, we will be letting research experience and observations generate the research question. But the products need to be use-inspired, but also of very fundamental nature, so that we can understand the fundamentals of how things are working and be able to provide the solutions. This would require evidence that is difficult to capture with existing indicators. This would need to collect, we need to collect the right data. We also need to capture the complexity in current practices, and there is a need also for us to use beneficial technologies like the ones in ICTs that we know today. In trying to develop a proper research agenda, our health research sector needs infrastructural investments, which would be better funding programs and multidisciplinary teams, which would be those in good governance with a decentralization and a delegation of responsibilities with a very strong presence of monitoring and evaluation. We need to develop information systems and data management such that disease registries can be effectively put in place, and operational research and health systems would be provided the kind of understanding for us to be able to distinguish between confounding variables. In the next slide. There have been 5 high-level options for action, and it is one in which countries need to establish an index of infectious diseases of poverty. It is one in which we need to embrace the One Health, One World strategy in relation to research for infectious diseases of poverty. It is one in which we need to activate the research ownership by the low and medium income countries. It is one in which we need to create innovative platforms to foster a culture of innovations that would benefit public health, and in one in which an online global platform for research resources needs to inform on strategies, policies, and funding commitments. In the next slide, I show you that the Global Report on Infectious Diseases made our recommendations, which needs us to improve on innovative approaches to research and development. It needs us to provide more funding for research and development, and all countries had promised to devote at least 0.01% of our GDP on government-funded research and development, and that 20 to 50% of these funds on health research and development should be pooled into a common basket so that we can approach and identify the problems with a common understanding of what is funded and what is not funded. We need to strengthen R&D, research capacity, and technology transfer, and that will be through the addressing of the capacity needs of academic and public, as well as private research organizations. We need to utilize direct grants to companies in developing countries and to have these properly coordinated. We need a proper coordination mechanism, especially on global health research and development, and the observatory that will provide the necessary infrastructure and understanding that the WHO can use. We need to formally negotiate with international conventions, through health diplomacy, so that the health global research agenda should be initiated and everybody would benefit from. The world has become a small and global village, and this is exactly what we need to see how the world is performing. There are emerging research capacity strengthening teams that we're defining here at Finistech or the Fabang Institute for Innovations in Science and Technology. We first look at the global enabling environment, the research operations, and knowledge management. But when you have all interventions, they either look at issues of access, targeting, and quality. And when you intersect both, they're defined for you in the next click. You will notice that these provide exactly the kinds of things that Africa needs to do to address both the communicable diseases and also the chronic diseases that are currently being present. In the next slide, I just show you the panoply of references which you can consult, which I used in preparing this talk. And on the score of that, my last slide is just to thank you for your keen attention. I think that the paper is now open for discussion.
Thank you, Prof. Mbacham, for your very interesting talk. So if you have any questions, please feel free to put them in the Q&A. But I will take the opportunity as chair and start the questions off.
Okay.
So you presented a lot of very interesting ideas with some tangible next steps that we need to start working towards to create solutions. What can we do now to get ahead of the curve so we don't get to the situation where we do have that convergence? If you could do one thing now to have the biggest impact, what would it be?
I think, thank you for the question and thank you for your interest. Actually, Gillian, if I was going to run for mayor of South Florida, I think I'll take you as my campaign manager. And thank you for all your kind words that you spoke at the beginning. I think what we are doing currently is the first logical step. There are certainly people who are connected on this on this webinar whose interest would be triggered by some of the things that I said. Maybe some of it is completely outrageous, but I'm sure that just by you and I talking is the first logical step. There are certainly things that we can do, we can put on the agenda. There are things that you would understand better. And just by having this crosstalk very frequently, so many things will emerge. The starting is now. There are certainly exchanges we're going to make between universities, some students from there coming over here, some of us from here going over there. This talk is what is necessary and essential. And then following that, we'll start to see where interests lie and people will begin to trigger these collaborations. And before you realize, something could emerge. There's so much of knowledge, especially for some of us who are trained in the West and in the North and have come back and here in the South and living with the diseases. There are things that we see, but we lack the means. There are things that you have as technologies, but you lack the disease. And so by us cross-talking, I think it's the first most important step that we've just made. Over.
Thank you. Dr. King, did you have things to add? Yes.
Yes. Just to say that Professor Mbacham has mentioned some of those, but just to say that coming back to your question, if we were to do something right now, what would be that priority? I think one of the things that we need to do in our African setting is to really invest in the health system. We need to invest in our health system to strengthen their capacity to address dwelling and sometimes even a try burden, even sometimes portable burden with the non-communicable disease and the infectious disease. But I also think that there are other social determinants of health, poverty, for example, education, access as well. It's also another thing. Take for example, one of the things that I see very often that it's a little bit causing a lot of cancer patients to eventually die in Cameroon is because no it mates.
We may have lost you. Oh, you're back.
Sorry, I'm sorry, the internet is a little bit not stable. But I was saying that there are other social determinants of health, and one of them, I would say, is access to health itself. Most cancer patients die in Cameroon not because, just because they know about their status a little bit late. Some of the symptoms they get look like they have malaria, and because everyone in Africa thinks that in Cameroon particularly think they know malaria very, very well, and they know.
Connection may be an issue.
Yeah, and it's raining on the side of the town in which he is, so it might just be some thunderstorms in the side of town.
Oh, it doesn't just happen in Florida, it happens everywhere.
Yeah. So I talked about social determinants of health, and I was trying to make a link between cancer and malaria that people get to know about their status a little bit late. And that's because they have symptoms, they go to the hospital and think they have malaria, they take drugs, they get okay, and go back, and they keep doing that for years, and they just discover that much later. But then also, one of the things that will be priority will be promoting the integrated care. Professor Mbacham talked about it. If we could do quite some training for healthcare providers to manage both types of diseases at the same time, I think this will be one of the priorities that we can take up right now if we were to do something.
No, thank you. Very good points. Jesse has a related question that he's posted in the chat, and so I can read it out. It sounds like policy making is crucial to health systems strengthening. What is the role of NGOs in this space?
Well, I think NGOs have a major role to play, but you would notice if you were to come to Cameroon and some of the other countries in the South, that policies we do not lack, but the implementation of those policies is what is worrisome. And I think that non-governmental organizations have played a major role in the sense that they have demonstrated very simply how some policies could actually be implemented. And just by guiding people on exactly what they need to do goes a long way in implementing those policies. However, it's up to us to look for other mechanisms, because NGO funding is not forever. And they also get the funding from other taxpayers, and then they make this available to us. They get that from philanthropy, and then they make this available to us. Sometimes it is just that willingness to show or help countries in how to implement a particular policy and what it means in terms of investment. Sometimes the politicians can't palpate exactly what that is. And if the NGOs can provide the resources and funding, and most of them have been able to do so, then slowly the country edges into implementing a particular policy. And then you see that there have been improvements, but sustainability also comes to mind. And African nations, if they devoted substantially just 0.01% of their GDP to health, research and development, then they would be able to sustain some of those initiatives that have been started by the non-governmental organizations. Over.
Thank you. Very sustainability is always a very important point. But so I will ask another question. As I'm sure most people on this call know, malaria has recently showed its ugly head in Florida, where there was 7 cases of Vivax. And given that Cameroon and African countries are very familiar with the context of malaria, but however, the cardiovascular disease and a lot of the chronic conditions that risk kind of increasing in African settings are very common here. What kind of exchanges would be something that we could build upon to kind of have that kind of chronic versus infectious disease transition so that we can potentially facilitate some of the transition and the kind of put the health policies and mechanisms in place to help deal with these different burdens?
Well, in my little understanding, and I think during my presentation, I tried as much as possible to demonstrate that inflammation is central. And if we could have a better understanding of inflammation, then the dual burden of infectious as well as chronic diseases could be properly managed. And I think this is the direction in which one needs to go. When you first mentioned that cancer, obesity, malaria, tuberculosis, diabetes are all inflammatory diseases, everybody, it raises an eyebrow and says, oh, really? We didn't know that. And so if we can understand more how to handle these inflammatory responses, then I think that we would be making quite a dent into how subsequently the diseases can be managed. We saw that. We saw the inflammatory responses when COVID attacked the world. And we saw that effectively the issues that resulted from a COVID infection was due to a cytokine storm. Again, this is just underlying that inflammation is central in the etiology of most of these diseases. And if we can address the inflammatory response, then we will be addressing both infectious and chronic diseases at the same time.
Thank you. So another question, did you see comorbidity with COVID and malaria in Cameroon, and how did you approach this?
This is an interesting question because the symptoms from COVID looked very much like malaria. What we did originally was that the conditions were being treated with some of the malaria medications. So you could diagnose in the same individual COVID, but as well as malaria. And if they treated for malaria, then both conditions seem to have disappeared. But also remember that most of the populations in Cameroon are the young population, and so we did not tend to see the severity of COVID and the presence of COVID and malaria co-infection per se, because everybody was now rushing. If you had a fever and you're coughing or sneezing, you just rushed to look for medications that could take away, alleviate the symptoms. I didn't even care whether malaria became very secondary. But people were able to co-test and show that during the COVID time, there was malaria as well as the COVID co-infections in the same individuals. And I think those papers are more or less coming out nowadays. Prof. Akinde? Oh, he didn't get me.
Oh, it's fine.
Yeah, Gideon, the question that was asked, I think it's a very difficult question, I would say. Very difficult, just like Professor Mbacham said, the symptoms being almost same, and with people knowing what malaria, I mean, they claim to know what malaria is, and without proper diagnosis, one cannot be able to really answer that question in the affirmative. However, we missed the chance of answering that question because at the time, we had another study, the outskirts of Yaoundé, where we're trying to look at all fevers, malaria, for example. But unfortunately, it was happening at the time of COVID. We couldn't have participants. I mean, people just deserted hospitals because they thought, well, if they come to the hospital, they will get infected and all of that. So it's a very difficult question to answer because of the symptoms that look similar, and that's really what we can't say what went well in an African setting like ours, because people were taking malaria treatment even though they had COVID, and somehow they got well sometimes. And so we can really say, I mean, that was a very difficult result.
Yeah, thank you. So we have another question in the chat, and then there's Frederick has his hand raised. So maybe we can start with Lynette's question, and then we can give Frederick the microphone. So first, what kind of capacity building would it take to be able to research inflammation in African settings? And how do you see the role of microbiome research in this setting of inflammation research?
Well, I think this is a very important question. And I just want to thank Lynette for raising it. The capacity building would be first in aspects of lecture, on aspects of molecular immunology, so that people get to understand exactly what are the underlying mechanisms. While that is being taught, it will be important to usher in new technologies, both in communication, but also in diagnostic technologies. The third aspect would be the analytical technologies and infrastructure to be able to make some of the determinations. And I think these are becoming very, very key and central in how the analysis and understanding of what's going on in an individual can be done. The facilities to do that are not very many. And if there's a research center that can provide the basics in how to understand molecular immunology during different diseases, I think that would be one huge research capacity. Now, I usually do advocate sometimes for what I call the Central Analytical Facility, or the CAF. And this is a central position where a lot of equipment is brought, and many people who do not use this on a frequent basis, but temporarily, can come and do the analysis and then go back and be able to have the results, rather than having institutions trying to amass some very expensive and complicated machinery in one location, which they only use some of the times and not all of the times. Again, this is particularly important. The second part of your question had to do with microbiome research. Yes, it is beginning to be understood and is playing a very major role. I have been involved in the microbiome research when it comes to diabetes. I'm trying to look at that with another student at the medical school when it comes to cardiovascular disease. I know that research has been produced in depression and the microbiome and how that affects depressive states. I know that it also may have played a major role in how exactly some of the African populations survived during COVID. But again, these are still emerging. And I'm sure in the next few months and years, we would see some of these research being published on how exactly that is happening. So the microbiome research, more and more people are getting in, but we need some form of documentation on all that is being researched. And I think the new technologies would help us document and put in one central place so that it can inform people later on. Professor Akinde is actually keen on modeling different aspects of human health. And I'm sure that this is one of the things that he's so eager to have the limited data we have and more data that one would generate, how the microbiome affects all other health conditions. Who knows, maybe by the time we combine the genetics of an individual and how there may be variants of the different inflammatory biomarkers and how the humans, with what they have as a microbiome, maybe we could find something exactly that points towards how populations are able to resist some of these infections naturally. And so, yes, I think the microbiome is one area of research that can play into understanding issues on inflammation. Over.
Well, thanks. Dr. Akinde, do you have anything to add before we move on to Frederick's question?
From my side, it's okay. Nothing from my side.
Okay, great, thanks. Frederick.
All right, good afternoon. My name is Frederick Ajimanjia from Green Grow Ghana Limited. I'm calling from, I'm contributing from Ghana. All right, so mine is both kind of a question and a contribution. To Prof, I want to know what other work are they doing to incorporate local herbs into your research, especially for malaria. I'm speaking because for us at Green Ghana Limited, we work extensively with NIM and bitter leaf as well. And then during the COVID in Ghana, as Prof indicated, for like in Cameroon, where most of the population was young, the widespread or the severity of infection and the mortality rate was very low. It was like that in Ghana. But one other thing which was very, very common and almost everyone who got infected used was neem. Just doing inhalation with a vapor that is coming from a soaked neem in hot water. So we know it works. We don't know exactly how. I don't know how much research that has been done, but at least for malaria, we know it as a preventive. We have a mosquito repellent that we sell. We use it as a preventive step towards the malaria. So how much or what work is being done in that sense, the use of African herbs in preventing the escalation of the malaria? Yeah.
Thank you very much. I think you just spun around and hit the nail on the head when it comes to the herbs. If I can go down back memory lane, in the 1918 flu, Spanish flu, that hit the world and took many more people than it actually should have, was resolved partly because there were two medicinal plants that were used in Cameroon and sent to the Western world to try to resolve the Spanish flu. And this was written in a novel in 1934, and which during the COVID period opened the eyes of so many people when I went on television and said these two plants grow here in Cameroon, and they were known and showed the records of how they were used during the Spanish flu. Now, as you would want to imagine, one of them is the same as the cinchona tree, and the other is another tree. But these were used during the Spanish flu, and you can imagine what that might have meant to you. So herbs are important, and because they form part of our diet, they might have helped us. We do not know. There's still some analysis that has to be done. But we're part of the team at the University of Yaoundé that trying to validate a mixture of 6 medicinal plants that was meant for various flu conditions and which were brought together to try to resolve the COVID during the COVID pandemic. Now, we could show an added value of these. We couldn't show any antiviral effects, but we could show the added value of alleviating some of the very disturbing symptoms and cough and fever conditions. I also know of the neem plant, and that was used by another physician in the handling and management of his COVID patients, together with other things, and these were put in different concoctions. I know that in Africa also, when we have a fever, we create a microsauna with a blanket and a few herbs, and we take this inhalation and the steam bath or a microsauna, and by drinking some of the brew that came out from what was boiling underneath, then we find some relief. Now, it is up to us to begin to learn the molecular mechanisms of these, to be able to validate some of the wonderful effects of these medicinal plants. But that research still has to be done. Why do I say this? I say this because if we have to do research and we must conform to ethical norms of research, then we must necessarily show that it has a beneficial effect, but we must not cause harm. And in trying not to cause harm as the second principle of bioethics, then we must show that in trying to cure malaria, we're not causing cancer. And this is exactly what we need to do with our medicinal plants, determine the toxicity at so many levels, and then be able to show its usefulness in resolving some of these infections. And I think through that, we're going to confirm some of the medicinal plants that are being used And yes, they have value, but we have to analyze them further so that they are not toxic in us trying to resolve a particular infection. Over.
Yeah, if I can take on from where Prof. Mbacham just stopped, the fact of toxicity. That's really the problem around in our setting. Actually, there is a student who is who we are trying to take now a master's program who wants to look at NIM and more like a repellent against the mosquitoes. Well, we're still looking at that protocol. But after the student takes up this work, for example, and finds some effect, the problem is to move on to the toxicity part of things. That's where, in our African setting, we go slow, and usually we are. I mean, I think we Africans as well. I mean, my setting, my Cameroon, for example, we are also those that are not encouraging this use of herbs, in a sense that we look at every herb that has been proven to be effective against any disease, very suspicious. And so these people who usually are not academicians, who might be, I don't know, what a traditional, those who don't know about this herb, they shy away, and it usually doesn't come to the limelight. I guess if there is I think to move on, not to research just on the effectiveness of this herb, but also right on the toxicity and the possible use by humans. I think this will further encourage the use of herbs in an African setting like ours. Thank you.
Yeah, just to add further, I think that Ghana has done wonderfully in trying to validate its traditional, the use of its traditional pharmacopoeia. And I think that we need to follow that example of Ghana, where things have been taken through animal studies and limited human studies, but also they have been able to validate how this has been used over the centuries to make the argument that at a certain limited dose, it's not as toxic. And then they've gone upon to do an improved traditional formulation, of the herbs. This is something that is quite commendable. I've also learned that in Ghana, as well as in Nigeria, there are wards in the hospital that if the Western medicine cannot resolve a particular disease, they're sent to these. I think this collaboration, I think the improvement, I think the marketing of these new approaches, including our traditional pharmacopoeia, is something that is going to go forward and which we need to promote. But we face one danger, that the medicinal plants may no longer exist much later on. So we have to make an active planting and encouragement of arboretums so that these gardens can stay and survive and that they are protected. And with the rapid rate of urbanization, it's clearing down the forest, it's clearing down all of these medicinal plants, and before long, we'll not be able to have them anymore. So I think it's encouraging that we see examples like that, but that we move one step further and start to domesticate some of these medicinal plants and show that they still have the same activity like those that were taken from the wild forest. And also look for secondary metabolites, which we can be able to harness and capture what active metabolites actually are working against this disease, and so that it is perfected. We cannot stay so traditional because the forests are disappearing. We need to move on and show how we can domesticate and be able to create conditions for having secondary metabolites from these same plants. And I think this is the way to go. And so, yes, when next time in Ghana, I will look for you. And I've taken down your name. I will Google. And if you're on LinkedIn, I would communicate with you. And this is the purpose of this webinar. This crosstalk is important. I said it as the first step towards any types of collaboration and any types of move. If we agree that we talk, we talk. And if we agree that we move further, let's look for ways in which we can move the agenda one step ahead. Thank you.
Thank you. We have 3 minutes left of our session today. Instead of, I think I'll hold my questions for another time, but if I can maybe give each Prof. Mbacham and Akinde 1 minute to provide their concluding thoughts.
Well, maybe Prof. Akinde first.
Yeah, I'm going to say so. In our setting here, the senior person talks fast. So I stand up. Just to say that there is a shift in the epidemiological transitions happening even in our settings. Non-communicable diseases are beginning to be a burden in our setting. The myths that used to exist in our settings about non-communicable disease being the problem of the West is beginning to vanish. We are seeing it every day. And therefore, it is very important that our different policies take that into consideration. How do we handle non-communicable diseases and the infectious diseases, especially those that have come to remain with us for a long while? How can we all provide our health system be able to handle that at the same time? It will be a very great way to handle this at this time. Thank you.
Well, I think first I just want to thank Gillian for having organized this. We have met with new names, Frederick Agiman Doa. We've met with new names such as Jesse Casanova. We've met with a new name, Lynette Menezes. And I think that this is wonderful. And I want to thank you for your questions. And so if I could conclude, I would say that let's invest more into the health systems and educate and improve on the research infrastructure. And let's continue to look at inflammation as central in the etiology of these diseases. Let's promote policy implementation and sustainability, which the local and international NGOs are trying to foster. Let's promote integrated care. And if we may go further in trying to build capacity, let's again look at how analytical and diagnostic technologies can make a major dent, and that we also consider microbiome research as part of the inflammatory response and how we can build this capacity. But let's not also neglect our medicinal plants and how those work. But let's us find out how to reduce the toxicity as well as look for its effectiveness in the resolution of infections and maybe other chronic conditions due to non-communicable diseases. The talk has begun. The time is now. Let's do it.
Thank you. On that note, I would like to thank everyone for their time and attention this morning or this afternoon, and look forward to continuing the conversations.
Bye.